you very much indeed for being our speaker tonight. We are very, very honored.
Thank you, Andreas. Thank you, Susan. Thank you, all of you at University of Bayreuth have been so gracious and invite me for this presentation. It's an honor, and I'm very happy to be here. And Arne Heinemann is a very convincing man because I had said that I couldn't do it because of COVID-19 this year, the epidemic. But he insisted. We had a conference call. He convinced me, and we've done this. Not only this presentation, but also a whole course I'm teaching on traditional public health surveillance and focus on COVID-19. So welcome and good day to all of you. If my slide can move, yes, it's moving. We're going to cover very many things, and bear with me. I'll try to go for 45 minutes, then we leave 40 minutes, 30 minutes for questions and answer, and you can ask these questions later. But you can send to the chat, because then Susan and Andreas and myself will keep a tab of what's going on in the chat. We're going to give a burden of COVID-19 worldwide, an overview of what SARS-CoV-2 virus is all about, traditional public health prevention and control strategies, and we're going to contrast that a little bit with the so-called additional prevention control strategy, the rationale, and what is it that we talked about, horizontal, vertical, social distance, lockdowns, and so on. Then we are going to ask the simple question, are we bending the curve? Where? In which countries, which regions? And then see the direct impact of COVID-19. And then hopefully you can go with me on my lessons learned. I could go on for 3 slides. I'm going to give you 1 slide on the lessons learned. And then my recommendation is very general. And then we can get into this. Like Andreas mentioned, the science is so big on this. I have so much material to show. I didn't want to get into any politics whatsoever. However, public health, it's about health. And health is the kind of outcome that everything matters in health. And especially the context, the infrastructure, the politics around any issue. And mostly because public health is delivered in many countries by government, not by private institutions. So politics matter, and it's life and death. So how are we in the world in terms of confirmed cases of coronavirus, the so famous COVID-19 cases? Yes, if you look at the number of cases worldwide, we went over 10 million now. This graph was produced on July 1st, and probably we got another maybe 2-3% or maybe 5% more than we had at that point. So United States, Brazil, United Kingdom, Spain, I give you a list, countries leading in number of cases. And China is there too, but not so much. See number of cases, give it a perspective, but a better perspective is the daily confirmed number of cases. What's the daily number? How are they changing over time from December 31st all the way to now? Which countries are getting more or less? So in here, you see the cumulative curve, that's a world curve. It's going up. Okay. However, other countries are still leading, but most of the countries, I would say 80% of the countries that had the big epidemic in the beginning, the new daily cases are going down substantially. The exception are United States and Brazil. Okay. Some similarities there. We can talk about that later. Total and daily confirmed cases per million. That gives a slightly different perspective. It's not about just the number of cases, but what's the size of my population, giving some density population. You can see daily new confirmed cases per million compared to total, the cumulative number. It's almost nil. Gives a completely different perspective. And here I'm doing the same. I'm looking at how rapidly this epidemic is going. Are we going too fast, to the right? Once the curves bend and become horizontal, that means I control that. And you're going to see that this is a graph that the x-axis is the days since the 100th confirmed case. Okay, so once I have the first 100 confirmed case, I start counting to my right. So it's almost synonymous with time, but it's not really time. But it's going to be more or less, the lines ends about end of June, July, by the 160 day. You can see that from January 22nd all the way to July 1st, more or less. I give that on the right side of the graph. You can see that some countries are very early stage, very, very, very early stage. They have really bend that curve very quickly, okay? We're gonna see more of that later when you say, are we bending the curve? So Taiwan is right there at the beginning, then Australia, South Korea, and then I didn't put all the countries in the world. Each one of those lines is all the countries in the world. I just mark a few so you can see those contrasts. And remember, I'm going to keep marking those countries because they are very contrasting, and I want you to pay attention to that. So you see US and Brazil going in the race. They're winning the race. United Kingdom, Spain, Italy, Germany, France, they all lumped together in terms of how rapidly are they increasing. They mean they already stabilized, but in the beginning, you can see the curve is going steep upward and then stabilizing at a later date, a later time. But you see the first one is Taiwan. Everybody else came very much later, much later. Confirmed case relative to the size of population. I show a little bit of that. I want to show worldwide, not just highlighting those countries. And you can see that Europe and the Americas had the brunt of it, okay? The total confirmed case per million, you can see Western Europe, very dark, right? That's about 5,000 per million. Same like in Soviet Union, Russia now, the Middle East and the Americas. Africa and Asia by July 1st had been spared for this huge onslaught of COVID-19 in terms of rate, which is real density. It tells what the real burden of the disease is. Confirmed cases, okay? Then you have confirmed case daily per million. And here too, you can see that at the very end, the dark 500 or more, the Americas are getting the worst because now they still have a lot of cases. This is by July 1st. And everybody else is going slow on that. You're gonna see a little bit more detail later on in the question at the end of the presentation, are we bending the curve? But I already give you a glimpse of it. I want you to pay attention to a country throughout. I forgot to mention this on those per million. And the country is Taiwan. You can see Taiwan is almost zero there, okay? All the time. Same thing, see Taiwan here, it's zero, okay? Now let's look it through the death eyes. What's going on in the world through the eyes of the death? What's the total number of confirmed cases? Over 500,000 deaths worldwide. United States, Brazil, United Kingdom leading. Like the number of cases, the number of deaths follow through. Very similarly, a few differences in the ranking in between. So if it's a horse race, yes, US and Brazil is leading the number of cases. When you go to population by included in a denominator, that changed. When you have the rates, Europe goes up. Daily confirmed cases of death worldwide is going up substantially by end of April, and it's going down substantially by May and making a little comeback, mostly because of Brazil and US. They're heading to the summer and they wanted to open the whole country and it didn't work too well. They're getting resurgent case. I'm going to show you a graph later on why is it happening. But everywhere else in the world is going down dramatically, okay? So total confirmed death, how rapidly have they increased compared to other countries? Again, you're going to see a country here at the bottom. You see that? Taiwan. I mean, they've been flat from day one. New Zealand followed through, Singapore, Australia. These countries did very well. I have a lot to say. We'll say that later on that. The other countries took longer to control the epidemic. You know, almost the x-axis here is not 100th confirmed case, the 5th confirmed death, okay? 5th confirmed death. After that point, you start counting to my right, which kind of a analogous to time. So if you hit that mark nearly zero by case 20 or case 40, that's about Taiwan. It maybe went up a little bit, not much, maybe about one case. We see the total number of cases for Taiwan, New Zealand, Singapore, but the other countries, this is logarithmic scale. So if you go, for instance, China, when they stop bending that curve here, okay, they're already about, you know, the end of thousands. We're talking about close to 10,000. United States, close to 100,000 on confirmed death, okay? So confirmed death relative to the size of the population, again, pay attention to that little country here, Taiwan. It's always very light, no dark shade. And then you see the Americas and you see Europe. Europe is way worse than the Americas, regardless of the number of cases. Countries like Holland, Belgium, huge mortality rate there. Again, pay attention to the little island here. Okay, you're gonna see daily confirmed death per million. And you see the Americans are getting, and the others are getting a little bit better now because it's a cumulative and the daily is affected by the change over time. Whereas the other one before is not affected for the total, it's a cumulative number. Socioeconomic impact of social distance strategy. I didn't say socioeconomic impact of COVID because it's socioeconomic impact of the social distance strategy. It's not the COVID. They didn't have that in some countries. They didn't do social distance like others did. So let's see, we're gonna go over that. What is social distance later on? How did the number of visitors change since the beginning of pandemic? I took England because it had a very detailed data that was happening everywhere else. It's a good example. You can see those lines here. 0 in the middle means nothing changed. At the bottom, going down, it's 50% decrease, 100% is the lowest line. You can see the transit station, retail, and recreation, which is like 40% of all the business in the world, have gone down to close to 75% and stayed down for a long time and is making a comeback, but still at 50% lower than before. That's happening all over the world whenever they had the lockdown. Just to remember that. They're about 50% by now, by June 28th, July 1st. Grocery, pharmacy stores, and workplace, there was a decrease, but not as much, but it's still there at about 25% reduction, maybe going back to 10%. Workplace, meaning everybody's going back home. Am I muted? No, because it's showing here like I'm muted.
Yes, not anymore.
Okay.
Sorry.
And residential didn't change much, and parks going back and forth. So that shows a little bit of detail. Let's go now worldwide. How did it happen? How did the number of visitors change since the beginning of the pandemic for retail and recreation? That's 40 to 60% of the business, depends on the country. If it's Hong Kong, that's about 80% of their business. They don't have big agriculture. So it depends on the country. So the red color, the dark color, same percent, 100% increase. 80% decrease is going to be this dark blue here. Almost everybody else in the world, it's somewhere in between 0 and minus 20%, with few exceptions in some countries in Africa and Mongolia. And to some extent, Guinea. No, goodness, I cannot even know my geography here. Oh, gee, somebody help with that one. But everywhere else, it's gone down, okay? Especially in places like India at that point, in South America and Europe. Grocery and pharmacy store, the same story, everybody's going downwards. It's going to decrease. In some countries had even experienced 80% reduction, like in Bolivia, which is amazing. And it's pretty significant in America. The lockdown have been very aggressive in places like Brazil. I have a network there. You couldn't even move in the street. The police will arrest you if you're on the street of the city of Recife, northeast of Brazil. For the past 2 months, you cannot walk to the beach, walk in front of your house, go anywhere. And the cars cannot travel everywhere. It can only travel in some specific major roads at only some specific points in time. So you're very limited. Throughout, like I said to you, throughout, you're going to see that little island there, completely in the 0. Okay? This is about transit station. Huge decrease for most countries. That was really most affected. That's public transport, cars, and things of that nature. Parks and outdoor space also is affected. Again, nada here, nada in Taiwan. Workplace, how did the number of visitors change? This is workplace, meaning people stop going out of the work. So I'm doing this through Zoom. I've been doing that for 3.5 months. I'm working from home most of the time. I only went to the hospital maybe once every 2 weeks. That's everywhere else. Same thing with residential areas. It's a little bit on the lower, but not much. It's about normal, maybe even went up because people are going back home. So the residential areas, whenever there's no lockdown or partial lockdown, people could move around in the residential area. So that going up. I'm not going to mention that, we skip that. Let's learn what's going on in the world, why we have this tremendous impact with COVID, what is different about this disease. So I'm going to dedicate about 1/4 of a presentation about what is all about COVID. So where is COVID coming from? COVID is likely, very likely, the genetic markers there are there. Let's see if I have something I had. No, I didn't do the percentage, but about 89% match with a bat virus. That's a coronavirus. Plus, we know coronavirus. There are 6 viruses that have reached out to the human transmission scale over the past 40, 50 years. We know about them since the 60s. So COVID, SARS-CoV-2, it's just the last in a line of 6 other coronavirus that we know so well. And they probably made that connection through the bat, possibly the pangolin as an intermediate host. And then this epizootic became epizootic between animals and human through the incidental host, meaning it's not your natural host for 50, 60,000 years. They are there, not affecting us. But then all of a sudden they made the bridge to it. A lot of theories about it. Good evidence indicates a wet markets in Southeast Asia, especially in China, but it's very common also in Vietnam, Thailand, and other places where people trade wild animals, especially exotic animals, for actually consumption, because whatever, it's exotic food became hot commodity in many restaurants. I saw an example, I think was in Vietnam. Anyhow, made us the host, and then through direct contact to droplet spread, we're going to see a little bit that later, likely airborne too, in my opinion. Then it makes to human transmission now, and that's what happened. First host, incidental host transmit to others, and now we all transmit it to each other. If it does reach the level of airborne, it would explain some of the transmissibility. But SARS, the other one, was not. It was just a droplet, and it does a good job in transmitting itself too. It's got same transmission rate. We're going to see that later on. So what makes it different? SARS-CoV-2 latch on the AC2 receptors in the human cell, and they're very rich, those receptors inside what we call epithelium. And the epithelium is the richest cell in your lung and your bronchia. So it's a respiratory virus that has this way of unlocking your defense through the membrane of the cell. I'm not going to get much in that. That's a funny thing for doctors. But angiotensin 2 or 2, AC2, it's very important for hypertension, for inflammation process in the kidney, all over the body, in the lungs. So not surprisingly, you're getting some effect in those called cytokine storms combined with that. It's causing a lot of the mayhem we see in older patients with chronic condition. We're going to see that. So here's the schematic, how they latch on, come up inside your cell, and then break down, leave the protein. That creates the so-called virion that goes and take an exocytosis, means exit your epithelial cell and start contaminating others. I'm not going to talk about much about the symptoms and signs of, because it's very common to all common colds and flus. The only exceptional thing is the loss of taste and smell is new. It's only about 20% of the cases. And it may give you a combination of diarrhea and some other things. The others do too sometimes. How do you detect that? PCR-based testing is all you need to remember. Detect very well, provide your diagnosis. It's acute phase infection. It tells if you have an acute infection. The serologic assays going through IgGs and IgM, the antibodies circulating in your blood, gives you an idea whether you have been infected before, because it takes time. It takes about 10 to 20, 30 days to develop fully immune response once you get infected. So they know that you've been infected in the past or as recent as about 2 weeks before. Okay, these are the two tests. The one that has the highest sensitivity and specificity is the PCR-based. It is more appropriate for acute, and that's what's being emphasized. There's a new test developed by CDC that detects influenza, SARS-CoV-2, and all kinds of influenzas, a multiplex assay. It just came out. Be on the lookout, takes influenza A, B, and a lot of other things. Effectivity. I want you to remember just one thing out of this rich slide that I imported from one of my lectures is the basic reproductive number. So that means one case of COVID-19 will infect 2.2 other cases. And the incubation time is somewhere around 5 and 6 days. Okay, that's the average median incubation time. Different publications give slightly different numbers, but they're all about that time. But it can go as long as 14 days. And that's why we think about the 14 days as your quarantine or your isolation time. Perspective of virulence, I'm giving you my perspective. Look at the SARS case fatality ratio in 2003. That's the cousin of COVID-19. It was estimated by WHO post fact, that means they have good data on that, to be 14 to 15%, a much higher case fatality ratio than COVID-19. COVID-19 has a case fatality ratio estimated in June, between February and June 1st, around 6%. It's very high, but it's not even close to what SARS case fatality rate was, and compared to something like rabies, 100%, well, 99.8%. How about that for case fatality rate? That's rabies, if you catch that condition. So another perspective of virulence is the comparison with influenza, the influenza epidemic in 2017-18 in the United States. This is United States. The other one on the top, SARS, and the others worldwide, but the other one is United States experience. And you can see that influenza A in 2017-18, which is the winter season, it's close to 50 million cases compared to 2.8 million so far. Let's say the epidemic is going down, as you saw the numbers, and even in the US is going down in terms of rates. So likely in about 2 or 3 months, it'll be over, and then maybe we'll have probably a resurgence around November, December. That's a winter time. But altogether, we're not going to reach even close to the numbers we had in influenza. Medical visits, I don't have data on that, but I had data on hospitalization. It's huge for influenza. It's nearly 1 million cases a year in the US, and it's so far it's been, at that point in June when I measured, about 35 different publications, 1,000 hospitalization. However, what calls the attention is the associated death, the number of deaths in US, 79,000 influenza-associated death in 2018 versus 129,000 for 6 months of COVID-19. So that's a greater death rate and ratio. A little bit more on that, I wanted to show this. Who is dying? Who is getting hospitalized? The red lines are all people older than 65. And I broke that down, 65, 74, 75, 84, 85 and plus. And you can see they're huge among these people. Rates of 600 per 100,000, 400 per 100,000, 300 per 100,000, 250 per 100,000 versus for the younger than say 18, 0 to 18 of nearly 1 per 100,000 compared to those. So we're talking about 600-fold, 500-fold, 400-fold, 200-fold higher group. So it's really hitting the old pretty heavily. But there are many hospitalization in the 18 to 49 at the rate of about 50 by now per 100,000. So it's something to look out. Who is getting it? This is data from US. Again, I made a list here on this graph. This is the relative risk, or the odds ratio estimation of the relative risk of what causes you to be hospitalized and get severe case and likely to die. Age, older age, top. In America, a black race, male, be a male, having a chronic kidney condition, diabetes mellitus, ever smoke, obesity, and hypertension. All the same risk factors have been found to some extent, except race. In China, in other countries, they have done similar papers. I reviewed 5 or 6 papers. They're all very similar. Obesity, hypertension, smokers, diabetes, chronic kidney disease, being male, and being very old. A little bit of perspective again. You see the picture of the epidemic of influenza back at that time, and compared to the same week of the epidemic threshold with a combination of COVID and pneumonia, influenza all combined. So that's the epidemic you see now of hospitalization. What about treatment? The evidence that I review about 15 papers on trials going on hydroxychloroquine, and 4 of them were positive, and 1 of them is outstanding, just came out about 5 days ago. There are 7 others negative on hydroxychloroquine. Very weak methodology in 2 of them. The others are decent methodology, but the great difference between these 2 group of studies, the one that showed positive hydroxychloroquine, they're done early in the clinical phases. And the others are all very, very severe patients that have been hospitalized. So it's like almost saying, are they really measure what hydroxychloroquine does, or what hydroxychloroquine does in a very, very severe case, which is nada. However, if you do early on, that's the trials that I saw it, it's very powerful early. So the evidence for me as a medical doctor and as an epidemiologist, I believe hydroxychloroquine is effective to some extent in dealing with the epidemic early stage if we could have treated a lot of people. India made a decision a few weeks ago to do prophylaxis with hydroxychloroquine, give one hydroxychloroquine pill a week to everybody every week for 7 weeks. So rest my case, I say my medical and epidemiological opinion, I can show the papers to you, is that hydroxychloroquine is actually powerful. May not be perfect, may not do every whole job, but it's some of the protocols. Hospitalized case is a different story. I'm not going to go into that. Let's talk about prevention. What is the traditional prevention control strategy and what the world has been done? I just want to remind you the corollary of public health surveillance, it's case identification, case isolation, identify contacts, quarantine the contacts, monitor both cases and contacts very closely, closer to you as you can get. Follow them up until resolution. Resolution is either cure, recovery, right? Complications or death. There's no other way. So that's what you need to do. And if you don't right at the early in epidemic, that's my main message. You should stop the epidemic. And that's what a few countries did. And we're going to show that later on. So outbreak investigation, vaccination, immunization. Immunization is still about 6 months away, in my opinion. Just to show to you definition, identification, list of contacts, refer the patient, the case, isolate the case, monitor it, and find until the resolution of the case. That's a case investigation workflow. Why we need to do that? Because of that. You see those red dots coming out? That's your expansion of a case, multiplying like it should. Remember, it's 2.2 for COVID. I played that with this model. That's a 2.2 COVID expansion. So you do the case contact tracing. Okay, once you have a case, you have the contacts, whole family, friends, anybody that's seen it in 14 days, you aggressively pursue every person, find about their status, offer testing for them. So basically identify, assign cases to the public health worker, test for COVID, refer to a doctor to follow up, and you follow up to quarantine, make sure this person's quarantined, monitor, and resolution. Find out about the resolution of that case. Additional public health measures. Do I need to have that? Yes. Once you increase the number of complicated and severe cases may overwhelm health system, you need to do something else. Well, people have done that something else en masse all over the world. And many times they went to that decision, this additional public health measure, without any evidence that their health system would be overwhelmed. No real evidence, no empirical. The evidence was based on something came along. I'm going to show you in a few minutes why. So for region country already in this phase of an epidemic, you need to flatten the epidemic curve. That's what was all over the news in the US with Dr. Fauci, giving lectures about that. Lower the number of severe and complicated cases. That's what you try to do, is flatten the epidemic curve. Okay, but there are ways to go about that, and there are ways of flattening what? We're going to talk about. That's what we want to do. Once you reach that level, if you've done the things right, you don't have that need to do flattening the curve. What you're doing with flattening the curve in a general way, I'm going to simplify. You're pushing the epidemic longer. Okay? You're going to have the same number of cases or more. You're going to have the same number of deaths or more. You're not diminish the total number of deaths. You just diminish them coming all together, or the number of complicated cases come all together in a very short period of time, not to overwhelm the system. That's all you're doing. There's no magic here. Public health strategy for flattening the curve. You do the traditional public health and add more elements. But you can add some other kind of policies like limiting national and international travel, enhanced screening, quarantine, that's traditional public health, ensure protection of all workers in the health field through PPE, correct personal protective equipment, personal measures, campaigns, hand washing, physical distance, respiratory etiquette, wear a mask, the best of all. I don't know why the controversy on the mask. You wearing a mask, you're not going to protect yourself. You protect others. Okay? By protecting others, you protect yourself through this loop of contagion and contact. So you actually protect the community, you're not going to get the infection. You don't protect directly, but you indirectly protect you and everybody else. need to wear a mask. Personal measure, community measures, suspension, mass gathering, closure of non-essential place of work, education established, reduced public transport. You're getting already into the suppression mitigation strategy. Let's talk about those two words. What do they mean? Both aim to achieve decreased social mixing, increased social distance, to slow transmissibility of infections. Comprehensive extreme social distance is called the lockdown. The mitigation is a little different. It's so-called, many people call vertical isolation strategy. You aim for a high-risk population. Like the old, the evidence is here. I showed the numbers recently. I showed the number of same paper 6 months ago in China, showed the same thing. The very old and the chronically ill are the ones getting the worst of COVID-19. So you need to protect them. Do everything at your disposal to do that. That's your vertical isolation. Your lockdown is a little different. It's very aggressive, doing all those measures, all in conjunction and more. So you're basically trying to reverse the epidemic growth, not just revert the growth of complications and death among the cases at risk. You try to not have that many cases at any given point of time and spreading and flattening the curve down. So the epidemic, well, for you here, it's this way, right? I'm doing my way here. Imperial College helped a lot to understand a lot of that through their simulation, but so did others, and so did the public misunderstood some of the information. I'm going to go a little bit about that, why we have gone in that direction so quickly. Everybody went. That's my theory. You watch my next slides and you tell me if I'm right or wrong in the discussion. Just remember, lockdown goal is to reach the reproducibility, like the transmissibility, below 1. Remember, COVID-19 is 2.2. One case generates 2.2 new cases. Here I'm trying to reduce cases. So I want to reduce that social contact. Why most countries adopt a lockdown strategy? That's my opinion. First is history, bubonic pest back in Middle Ages, and a few coming back here and there. Spanish flu 150 years ago. Yeah, but it's not contextualized. It's lacking that evidence because I cannot replicate that world back then to the world today. So there's no context. That was not a justification for going complete lockdown. Plus they didn't do good lockdowns for the modern ages. Some examples, simulated impact, mathematical model. I think that, together with the WHO initial recommendation, were the things that was everybody's mind. As a faculty in a university, talking to students, talk to colleagues, that's all they talked about. And as a doc with a network of friends all over the world to connect with me to WhatsApp, everybody was asking me about that. So they are really keen on learning more about the Imperial College, the University of Washington, and others. I quote some others, a simulation model. And the WHO initial recommendation for social distance based on China's lockdown experience. That's pretty obvious. That's what they made. 2 months and a half later, they have to go backward. They say, oh, hold on, lockdown is not for everybody. Too late, my dear. Everybody already bought into that Kool-Aid. Internet, that's another one. Everything people start believing now, it propagates incredibly fast through internet in ways that I've never seen before and already shaping minds and ideas. So that's it. So what do you mean by those simulations? Simulation is based on an old model created in the 1920s, brilliant mathematical model that basically looking at susceptible, exposed, infected, removed, but make very many assumptions. I gave you just 3 of the assumptions. Some of them may hold, most situations, but there are like 6, 9, 10, 15 other assumptions, depends on your model. So these assumptions are hard to hold in some real world. And any mistake, those models are so-called exponential models. So if you make a tiny mistake of a 10% in one assumption, it may mean a few thousand deaths here. It may mean a few million deaths in this other model. So just think about it. Different degree of social distance are imposed in the model, in this model of susceptible, exposed, infected, removed. Okay, once you impose those social distance strategies, you start simulating what the number of cases should be, what the number of deaths should be. And you can also, like Imperial College did, try to look at the hospital capacity, and what University of Washington did that too initially. Later on, because the press was all over the simulation itself, they forgot about surge and hospital capacity. they start focusing on the models of new cases and death themselves. Initially, was to help people to prepare for surge in hospital capacity. Well, University of Washington model, as well as Imperial College. Later on became, its own element. Imperial College modeling shows that Britain should have had 510,000 deaths without any major lockdowns and aggressive social distance and vertical distance, controlling both. US should have had 2.2 million. Well, the public health actions here is not like not doing nothing. Like 2.2 million is doing nothing. Just stay status quo. Why not doing nothing? Normal, traditional, with no lockdown. But what we did here is not too different. And we don't have 2.2 million deaths. Not even close. We're about 112,000 right now. Suppression mitigation would reduce peak critical care by 1/3. That's what the model in Imperial College basically promoted. That's their model again, just to show you that the vertical, the black color here, the black line, is what would do nothing would do to those countries, England or US. You only model those two countries. The red line is your capacity, your hospital capacity for ICU in complicated cases. This is your total number of do nothing. Case isolation, it would be like the orange. You isolate the case, you reduce substantially. If you just close schools and university, it's not much better than do nothing, just a tiny bit better. But the case isolation make a long way. And then if you isolate cases, home quarantine the contacts, social distance of the older than 70, that means high risk, vertical distance type of approach, you bring that down substantially closer to what we want it to be. Okay, still not there where we need to be, but it's pretty good. There's another model that I review that compare vertical versus social distance. And they found out the vertical distance has a marginally better than no social distance or doing nothing. Whereas the horizontal distance did a tremendous impact. So they conclude, their paper concludes vertical social distance policy is ineffective to contain COVID-19 pandemic. I think I would not totally agree with their conclusion and the title of their paper, but that's a discussion. You can ask me why. We discuss it later. This is their model, do nothing. This is where you expect the ceiling. Everybody will hit ceiling. And the black line here is the currently infected across all ages. The top one is the so-called 25 to 59 years old. The green one is the 10 to 24, and so on and so forth. So they model that and find out that the horizontal distance will be tremendously impactful. Vertical distance, a little bit less impact overall, but on the 60 plus the vertical distance of their model brought that down substantially. You're talking about nearly a 30% or 40% decrease in number of death of cases. So public health strategies adopted by countries from relaxed to lockdown. I'm going to use for you this government stringent index created by the Blatvanik School of Government, University of Oxford, and is taking data from 9 indicators. And 0, it means the laissez-faire, almost no social distance at all. 100 is the strictest response you can get, like in China, it's close to 100, and Italy and France to some extent, and in Spain. So here, to exemplify this lockdown, I put some countries for relevance. This order here that I show on the left, 1, 2, 3, 4, doesn't really mean, for the first 4, actually it's true, but for the others, they're not. Sweden is not a 6. There are many other countries in between. Taiwan is really the lowest, but maybe there might be another country. I doubt, maybe Taiwan and Iceland and Australia and Singapore may be lower here. So response stringent index. I'll follow one for you so you can see how this works. China, early in the epidemic, in early mid-January, went down up from whatever they had to about 80 in terms of lockdown, in terms of stringent index. And then higher than 80 at some point later, but very high, kept very high until March 21. They start relaxing in Hubei and Wuhan province. And then they had resurgence of cases at that point in April, late April. They immediately went back up to higher than 80% and kept it high throughout, well, the little blip here. Similar thing happened to France, Spain, Italy, but much later, at a much later time. You see that here? China started very early. They started very late, especially places like, I think the green one is Italy, is the one who started earlier, but France started much later and Spain much later. Taiwan, on contrary, has remained very low-key at about 20, with a little bit higher from 20 to 30 stringent index between March and April, but came down to what a traditional public health, very close monitoring system does. So how did it go in the world? How did it go? Well, again, look at Taiwan, the little island here. Okay, Australia, New Zealand. This is school closure. Those countries did not close their schools. Okay, so did Norway, did not close schools. But look at the dark brown, that's the whole Americas, most of Africa, Asia, and Spain, England, to some extent, Germany. Okay, a lot of school closure. Nada in Taiwan. What about workplace closure? A lot closure everywhere else in the world. The worst is in Canada, China, some other Middle East, Eurasia type of countries, Africa, but nada here in Taiwan. Public events, cancellation, everywhere else in the world, huge cancellation, nada here in Taiwan or some other countries. Public gathering, everywhere else, very, very restrictive public gathering. You can see this dark blue here. Only 10 people allowed less in any place in any given time. Very well restricted. Nada in Taiwan. Taiwan didn't do any of that. Public campaigns, that is different. Everywhere else in the world, people did, all government did, and all public health systems did everywhere. So that's comparable across the world. Stay at home, very aggressive everywhere in the world. See this dark brown, orange? That's aggressive lockdown at home. Nada here in Taiwan or Australia or New Zealand, for that matter, or Iceland or Greenland. Public transport, a lot of places had incredibly restriction, like in South America and some places in Africa and Asia. Some others are in between, and some countries did not, including Taiwan. Internal movement, people could not move around. Everywhere else in the world, very restricted the movement, especially in the Americas, most of Africa, Asia, France, you had a pass, England, but look at Taiwan, nada. International travel, that's different. There's some level of ban, very targeted in Taiwan, but very mild, I would say, not too dark color. The other countries had incredible bans. Testing policies, that's different. Many countries did good, but what it doesn't show here is the time of it. Many of those who did well in terms of testing, they did very late in the process, okay? Taiwan did very well. It's a very dark shade too. So testing per 1,000 gives some idea. I'm gonna skip that quickly. I wanna focus on this one, which is testing per new confirmed cases. Meaning when you have that, you have an idea how countries are really doing well in identifying cases well, because it's so well distributed, it's so well done, it's so effectively delivered. And you can see, again, the listing, who does better. Australia and Taiwan are way ahead of everybody else on that component. The other countries in the middle, we're talking about thousands. This is logarithmic scale, folks, too. And therefore, this is just 100 for most of Europe. And then Sweden is the one that hasn't done much. It's very low. But look at them, Australia and Iceland, huge effectiveness in delivering testing. Contact tracing, very powerful way of control, big in Taiwan, all over the world, done in different times in many places. That's part of the problem. And some of them done in conjunction with suppression, where Taiwan, there was no suppression. It was just a little bit of mitigation with traditional public health. Income support, many countries did. The biggest income support came in Europe, Canada, US, and some other countries did too. It's all over. Debt contract relief, many countries did. Taiwan did somewhere in between for these two. So overall, the GRSI, which is the index, is very dark everywhere in the world. You see that, especially in the Americas, most of Asia, because they have lockdowns in many of these places, in England, Ireland, a lot in Europe, but it's from kind of a 40 to the hundreds in terms of stringent. Look at Taiwan. It's between 0 and 10, the stringent index. So empirical evidence of lockdown impact from countries locked down. I gave you 3 countries who had lockdown, and guess what? It worked early in the epidemic. Give you the China lockdown. They closed everything. You can read it, but I show you how they did. 11 million people in the city of Wuhan and Hubei province. And that's the total number of cases. By March, they have reached that number and then stabilize at that number, and then 3,139 deaths. Given the size of the population, 1.5 billion, I mean, that's remarkable. Lockdown work at China, okay? Now show Italy and Spain. You can read it, but I'm gonna go quickly on that. These 2 cities are in the same country. Lockdown was done a little different in time. One started much earlier, nearly a month earlier than the other city. And so Bergamo continued to have cases, and Lodi had incredible effects. Similar lockdown, similar countries, similar culture, similar people. So lockdown worked. Empirical evidence right there. Now let's do traditional public health. You saw the stuff from Taiwan throughout. What they have done. If I could simplify what they've done, Taiwan, what they did is just doing traditional public health, done right. They had 189 policies that did not change the traditional public health approach, which is identification of cases, isolation of cases, contact tracing, and quarantine of contacts, done right at the beginning of the epidemic, massively, well done, testing, distributing masks to 4.5 million people in Taipei. Can you imagine that? Distributing sanitizers, hundreds of thousands of alcohol gel sanitizers free to the population. Immense public health campaign. Lots of the laws and policies, restriction for outside move, initially from China, and then expanded to include the whole China, include other countries in Asia that Chinese visitors or Chinese people could come through, and then doing Italy and then Spain, and little by little start blocking, segmented at the right time, but also using high tech to do this contact tracing, high tech to do the isolation. So every patient that was isolated with a case received a cell phone given by the government so we could follow and monitor that person 24/7, every hour of the day. Okay. They also had the QR during the airport. You go to the airport, you set this QR code while you're still in a flight, and they could segment you in different groups, possibly high risk and so on and so forth. You have to go through it, and then you do a screen, a very detailed screen, and then you send out, yes, you can go anywhere, otherwise you go self-quarantine, or I will find a way to find you and isolate you, give you a cell phone and isolate you. So it's just amazing, and it worked. They had 446 confirmed cases, 24 million people there, 7 deaths since the beginning of the epidemic. On a per capita base compared to US, US has 1,200 times as many deaths as Taiwan did. Yes, I'm not comparing the rates, folks, just the number of cases, but that's real numbers, okay, of cases. No economic downturn. Schools, workplace, retailing, grocery, all other services open. Travel continues, the restrictions, city or any community life didn't stop. Growth, we slowed by 1.5%. Yes, COVID has an impact, but compared to double digits slow in growth of the economy US, the biggest and fastest moving and the most dynamic economy in the world. Unemployment, 4.1% in Taiwan, increased a tiny bit because of COVID epidemic, 16% unheard in America, 10% during the Obama time, during the major recession. People are going crazy. Oh my God, 10%, 16% now in US. Empirical evidence, I'm doing a little bit all across the world so you all can see with your own eyes. Are we bending the curve? So bear with me, I can show to you how this graph works later on. The daily confirmed case per million gives a very good idea if you're really controlling the epidemic. Taiwan doesn't even show, the numbers are so small, they're not in the graph. I'm not kidding you. I put the note here. Taiwan is too low to show in graphs. China did control that very early on. Complete lockdown. Complete lockdown. The other countries suffer a huge brunt especially countries like France, Italy. By the way, this is confirmed case per million. You can see this, you can calculate this area here, integrate this area, and get the size of the excess that they had because they could not control the epidemic early. Okay, and Sweden did much better at the beginning, but now it's kind of right there, that beginning to control. It's going down finally, but France and Italy and all the other countries are there. Trust me, I put them here because the line's confused. It is hard to put a name and the country. This is even better. This tells exactly how early in the epidemic this whole bend in the curve start happening. And this is really bending the curve. You can see Taiwan after 100 cases, about between 100 and 1,000 cases, that's 440 cases. The whole epidemic, new cases, total cases start disappear. You stop the epidemic right there. China, on the other hand, came way later. You see that here? Australia and South Korea controlled much earlier in the epidemic. China came all later. So Taiwan is not, it's not a suppression lockdown. Everything was open. Taiwan is traditional public health using technology, education, massive public health campaign and organization. China is a complete lockdown, suppression level reached. They're not even Italy and France. Well, they got close to China, but not much, okay? And they came way later in the epidemic. France, Italy, United Kingdom, way later too, okay? Australia and South Korea use some of the cues of Taiwan in terms of using technology and doing aggressive public health, but also a little bit of suppression, a little bit of the feature lockdown. So you can see here, I'm not doing an experimental trial to you. I'm showing data worldwide. This is data from CDC Europe. It's fantastic data. Case fatality rate, another way to look at. The highest case fatality rate by the end of this epidemic on June 21st, France. So there, yes, the French claim 2 weeks ago, Macron was claiming success. I say I'm not going to mention politics. Sure, I mentioned the name. But the country of France claimed they do done successfully. Oh, if you measure case fatality rate, no, you didn't. Look at Taiwan. It's close to 0%. Look at Iceland. Germany do way better than anybody else. Nearly as similar as China in terms of case fatality rate. A little bit of suppression, but not as aggressive as Italy, France, Spain, and China. Okay, and right there. And Sweden is not doing worse than the others, doing a little bit better than Spain, Italy, and France. And laissez-faire, they've done nothing. Okay? Are we bending the curve through the eyes of the deaf? Again, do you see Taiwan and that here? It's too small to show. China did a good job, but it picked up back again. You see that here? When they start slowing down the suppression and start picking up again, they suppress and then came down again. Spain did the same thing. When they start relaxing, came down and went up. They start doing the suppression. Now they're beginning to deal with that. France, Italy, Germany, Sweden, all coming down. They're all bending this curve already. So, daily confirmed death is really bending down, comparing all these countries. I've showed that before, but I've given you a little bit more country to show where US is not even close to bending the curve. Well, it's beginning to, okay? But that's too late in a lot of death. Look at Taiwan, my God. Resurgence in US is a fact, and because of holidays and bottom line, the strategies, there is no strategy. Every state was very independent. Some did a little bit of suppression, lockdown, some did nothing, some did vertical. It's a good experiment to look at, but everybody did a little bit of suppression, I have to admit. But there's no coordination between federal and state as much as you like to see. So what are the lessons learned? If you want to stop an epidemic, start early, regardless of this strategy. China and Taiwan and Singapore, Iceland, Australia, New Zealand, they all did much earlier. All those things, whatever they did early. Traditional public health surveillance works very well. Case identification, case isolation, contact tracing, quarantine of contacts, public health campaign, equipments protecting people, guarantee that people have a way to go about hygiene and the general ideas of social distance without really doing lockdown. And if you add a little bit elements like Taiwan did, like stratification, a little bit more aggressive on the social distance of the old and the chronic, and more importantly, international travel bans early on. critically look at the data coming from airport, very monitor everything at the airport very closely. And through I'm going to have a whole lecture, create a lecture on public health data informatics in Taiwan. It's amazing. Okay, so that's what they did. Mitigation strategy, vertical isolation. Through simulation, it shows it does work. There are many advocates, but it would definitely have a dent on the old and the chronic. And I showed to you who are the one having complication and hospitalization. Is the old and the chronically ill, not surprised the other one dying. Even 6 months later, people say, oh, this is just the beginning. Maybe they start getting, remember, influenza A and B kill a lot of young and infants. Okay, not the case with COVID. It'll be a rare case. Okay, infant death for influenza A and B happen in great numbers. It doesn't happen with COVID-19. It's going to be a rare case. Okay, not a common case. Widespread misunderstanding of the goal of vertical isolation. It's not to slow the spread of COVID, but rather the spread of COVID-19 in a high-risk population. So that will decrease severity of case, hospitalization, and ultimately death. Another lesson learned, comprehensive suppression strategy, lockdown, it's an effective public health strategy. But I made the point here, it's much greater in the simulation models than in the real world. Look at France, look at Italy, look at Spain, compare that to Sweden, okay? Effective lockdowns are infeasible in most of the less developed countries and other population segments. My 150 docs who graduated with me in 1981, they all send me a message, how do I do a lockdown? These poor families that I see, 80% of my population live 7 to 10 to 15 people in 2-room household. 10 people sleep in the same bed sometimes. This is extreme poverty. How do I do lockdown? How do I do distancing? They don't have water and sanitation. 50% of their towns and cities. Are you kidding me? It took nearly a month and a half for WHO to say, oh, I forgot about those guys. Oh, it doesn't work everywhere. Lockdown negative effect will be felt for months and years after the epidemic. Social determinant of health matters. In 1964, during the Alma-Ata, the whole world except US accepted that poverty is cause of ill health and death. And there is a FAO-related data. I put a stop, but I couldn't find it. I'm going to find it. But don't reverberate that because I'm not sure what the source is. But there's an estimation that says that they predict 1.2 million infant deaths attributable to lockdown in the next 12 months. Well, that pales, the COVID 500,000 death pales in comparison to that. 90% of those deaths are older people, people with chronic disease. Doesn't mean they need to die. But if you put the value, 1.2 million infants dying because of poverty created by lockdown, you have to think about that. So my recommendations are 6. WHO participating countries should carefully evaluate the steps taken and communicate a new emerging disease. It took too long from the early phase in early November in Wuhan, in Hubei, for the notification in December to WHO and then to the whole world. That process took too long. By convention and by agreement in the World Health Organization, countries have about 15 days to notify a new emerging disease. So they can take precautionary measure, they can take preventive measure, do what Taiwan did. Maybe Taiwan knew early on more than anybody else, I don't know. Probably not. Probably it's just a closeness to China. They know it's coming and they are aggressively pursuing something earlier. But that needs to be revisited, needs to be assessed, in my opinion. Public health surveillance officials in countries in the same geopolitical regions should lead the prevention control action without waiting for this consensus worldwide from what WHO, yes, should follow WHO recommendations to a point, but if you have that at your door, don't wait for consensus, start acting immediately. Activities in the wet markets in China should be continuously monitored for episodic transmission potential. That's the 6th, that I know, 6th epidemic reaching humans coming probably through the same epizoonotic thing, and the wet markets have been implicated in all of them. We need to pay attention to that. World Bank, OECD, and other economic multilateral organizations with cross-country reach should create an emergency fund for economic relief during future infectious disease pandemic. You saw in the map that US, Canada, some European countries, and some exceptions, some 1 or 2 African countries did a lot and protect the population economically, but everywhere else in the world, it was hard to do that. And this economic downturn is going to affect lives and health tremendously. So we need to think about that. WHO should evaluate the impact of lockdowns on children's health and survival worldwide. I want to see the effect of that. All WHO participating countries should commit to strengthening to maximum capacity, as tested by the COVID epidemic, their public health surveillance functions of case identification, detection, and contact tracing. We need to do this better, faster, and use technology like Taiwan did. Everybody should do that. I know for a fact, not going to mention name, that many governments in the Western world have over the years defunded those public health strategy. Once the infectious disease goes away for too long, people become complacent, okay? And they start not paying attention. So we need to have those systems reinvigorated, invested, and trained. People need to be trained. And that's why I'm giving this training this week to Universität Bayreuth students on contact tracing, public health surveillance, and the epidemiology of it. Thank you. You've been a wonderful audience.